Well, thank you, Jim, and thank you for the invitation to come and celebrate Education Day with you. And so I thought today that I would just reflect a little bit on surgical bedside teaching. As Jim mentioned, I've had the privilege really of being involved in the Surgical Education Research Fellowship. And to me, one of the things that has brought me joy in my career is watching young people sort of come into surgical education. It really has, as Jim and I were talking about last night, it's become an accepted academic focus. Whereas in the late 90s, when I told my program director at the time, hey, I think I'd like to focus on surgical education, he said with grace and encouragement, that's a dead ender. Like no one will ever hear from you again. So I think I've proved him wrong. I haven't called him recently to check, but it's been lovely to sort of see the world shift, because I actually think his advice was probably the credible advice at that time. I have no relevant conflict to disclose. I'm not going to be talking a lot about my own research here. This is really sort of a position piece and to sort of gear us toward the future. My full-time job now is as a chief wellness officer, so I am pleased to be able to talk about my other passion, which is surgical education. The truth is I sort of fixed wellness at UAB a couple of years ago, so I wouldn't have much to tell you since we've got it all sorted out. But in this presentation, I'm going to be making lots of unsubstantiated assertions for you to consider. So that is the disclosure that I'll provide, although I've tried to sort of dip into the evidence, some of which actually comes from Stanford. I think you'll be curious to see as we sort of think about the general concept of bedside teaching. So recently, I've retired from clinical practice about a month ago. So I've been kind of in a reflective phase. And as I was thinking about like, what do I want to do with hopefully the next decade of contribution that I can make, what might that look like? And so a book was recommended to me called Strength to Strength, which is talking about like your second half of life. So I'm way behind. I don't anticipate living to be 140, but we'll see. So it's interesting because it's probably something I should have read a couple decades ago. But in it, they talk about the Cattell-Horn-Carroll theory of intelligence. And what it basically shows with lots of empirical evidence is when we're young, we have a lot of a particular kind of intelligence called fluid intelligence. And so if you think about children, they're super creative, super adaptive. And what happens as any of us age is we accumulate crystallized intelligence, but we lose fluid intelligence. And this is interesting that it's pretty well accepted in theoretical physics that if you're going to make a major theoretical contribution, you'll do it before you're 30. And that after 30, it's uncommon for a physicist to make their contribution. Interestingly enough, and probably too late for any of us, jobs that are better in old age are historians, actually. Their contributions typically occur in their 7th decade of life. The other job, of which I don't even really fully understand, is lyrical poetry, actually. So if you're a lyrical poet, that's something that tends to be better rewarded late in life. So there's no way I can avoid being identified in this group. I'm sort of getting used to the label that gets tossed to me sometimes of old white guy. It's, I don't know that it's meant as a compliment, but it's hard to disclaim any of it. But what I'm not going to do today is like harangue younger people, talk about the good old days, advocate for returning to them. Having lived them and having my memory intact, they weren't so good in some respects. But I do think we're in an interesting time in transition in terms of how we do patient care, how we teach, that it's good to sort of pause and for me to sort of share some reflections based on my own experience and the crystallized knowledge that I've accumulated. So this was sort of a bedside phenomenon that occurred to me. I was running over as the chief resident. My attendings had a private office. I had my own clinic, and I was running across, and from 30 feet away, I look into a room and there's a family, and the child looks up and I see this from 30 feet away. Anybody know what this is? Right, and this, do you know the name of the finding? So it's called cat-eye reflex, because what happens is the retinoblastoma basically displaces the normal tissues of the retina. And so when you shine light, the one eye is white. because that represents retinoblastoma tumor. The reason I even knew about this is being at St. Jude, I put lots of vascular access in kids with retinoblastoma, so I had seen it. But literally walking 30 feet away, light just happened to see hit the kid's eyes in just the right way, and I made the diagnosis. And I went to my attending, who was the one that I respected and probably feared the most, and I said, I think you should have this kid seen. I think he has retinoblastoma. Sure enough, was confirmed with a proper exam. And I did think, and you certainly don't want to advocate for things that are self-serving as the learner, but I do think that he was actually a little bit more respectful of me going forward, because I had, really helped him out. I mean, we made a diagnosis that probably would have been missed. But that's just an example of sort of a bedside encounter that was pretty remarkable. So this has kind of been my observation since really in the last 20 years, the EMRs just become integrated into anything we do, that this is kind of my view of residents these days, is they're typically over trying to navigate through the electronic health record. Many of you know Nicole Roberts' intraoperative teaching model called BID. So before, intraoperative, and then debrief. And so the before has been eliminated because we don't scrub anymore. They used to talk about, yes, during your 7 to 9 minute scrub at the scrub sink, that's when you would have a conversation, like what would you hope to accomplish in this case? That got replaced with squirt, squirt, go, right? Because we're all using the alcohol-based things. And then the D part of it got eliminated by this, because many times I'm like telling the residents, look, you're much more facile putting orders in. Why don't you break, go do the orders, I'll put the dressing on. And so we sort of break it all out. So we've lost a lot of that opportunity, but it does seem to me that the residents now are really focused around receiving information through the computer, in contrast to pre-computer, where you had to go up sort of and physically sort of gather information by going to the bedside. So I think this is one of the things that we're dealing with. Again, in the theme of not hearkening back to the good old days, it used to be also that you got dispatched to go get x-rays because they didn't exist digitally. And if you were the chief resident, to appropriate the x-rays, because if I needed them for a case, I needed to have them, right? So we would steal them, in other words, from the file room so that we have. And so that's been a lovely advance by having them all digitized. So just to show that we're a work in progress, this is our team doing what we call running the list. And so every morning at 7 o'clock, we assemble, and then they print like a paper thing, like the old-fashioned newspaper, a list of all of our patients, typically somewhere between 50 and 80 patients, and we just go through patient by patient. And typically the fellow will say, this is so-and-so, had an appendectomy yesterday, doing fine, going to go home today. And that's the extent of it. And so we don't make rounds like in my era of training, like my pediatric surgery faculty, we rounded, physically walked around, saw every patient on the surface every day. That's all been displaced by this. And so it would not be, I did it one day just to see what it take. It took like 3 hours to see 80 people. I mean, if you actually examined them, so I'm like, I get it. Who among us has the time to do any of that? But this is just, I don't, you may be more advanced than we are at Birmingham, but if this sounds like your life where we're just constantly frenetic. And I do think it's been an interesting outcome of the 80 hours is we've gone to these multiple handovers. That's why I'm not envious of your youth if you're a resident, because it just feels like they're spending so much time constantly handing over, because I've got to go, I've got these rules, I've got to turn things over. And so there's so much more time devoted to constantly sort of exchanging information. So they typically meet at 7 with the attending. We try to make an intelligent story or two, a comment, whatever. And then it's off to go. And then they reassemble at 2 before the nurse practitioners leave, kind of run through the list again. And then typically they'll do like a night. So 3 times a day, they're kind of running through this list. At no point do we ever stroll around and, see anybody. So that's really kind of where I am in observing and pondering and just thinking about, do we need to take this opportunity to think about bedside teaching? So I'm going to try to convince you that we should care after I define it. And then I'm going to give you two different models, and really, and I'm going to give you a challenge, because I think your educational group has really expanded in impressive ways. You have some young scholars here, so I'm going to present a possibility for a young person to maybe undertake. Young being defined, anyone much less than 58, we'll say, would classify as young. So this is what I'm meaning about surgical bedside teaching. So the two models that I'll show you are really developed by primary care doctors based on clinic teaching. So my wife is a extremely bright physician scientist. I was telling the story last night that I've gotten so accustomed of her winning awards. And the first time I'm kind of like Prince Philip here. I'm just existing to hold your purse, right, for the Queen. And she's like, that's not true. And then the chancellor was coming around and they got ready to give her an award. She turns to me and said, could you hold my purse? And I was like, cool, told you. So the most recent time, because there's been many, I said, at least make sure your purse coordinates thoughtfully with my shoes, because I'm going to be carrying your purse more than you'll be carrying it at this event. So we've come to that nice accommodation. But when we were going through med school together, we had done surgery, and I was surprised that I liked surgery. And it was really the nature of the work. And some of the surgeons were truly inspirational people. And she said, I really love working in the operating room. To me, that's a very special thing compared to all the other things we've done. And she said, oh, I purely hate it. And I was like, wow. And I was like, what do you like? And she said, clinic. And I said, oh, wow. I don't know if we're going to be able to make it as a couple. That is just wrong. And so I think for surgeons, we've typically viewed clinic as being like a punishment, a place that you get sent instead of doing the cases. And so we're going to broaden. I'm not talking about teaching in the clinic or so-called ambulatory teaching. I'm going to argue that we could apply these same methods to any bedside teaching, and that particularly those of us who teachers need to be deliberative about saying, let's go to the bedside. Like we'll do this, like we'll have a kid, like for example, necrotizing enterocolitis, which requires a lot of judgment. And I've had the instance to say to the fellow, like, what are you thinking? They kind of got thrombocytopenia. They've got some pneumatosis. They were having increased vent. And I'm like, well, let's just go see them. And they always look startled at the suggestion of, yeah, let's actually go up and sort of see the patient together and glean information from the physical exam. So this is what I'm talking about when I'm talking about bedside teaching. So reasons that you might care. And one is there are still conditions that you can diagnose based on history and physical exam that no ancillary testing is required. We have this constant kind of grumpy discourse in my group about CT scans for appendicitis. And like there's good literature show we should not be doing CT scans regularly for appendicitis. And yet the ER doctors either done it or the referring physicians either done it. And so we present with it. And so, I really think that there should be cases. It's hard to imagine anymore that you would do it with no imaging. We certainly have pushed doing ultrasound, but there is a case to be made that there are conditions that you should just be able to treat based on what you observe at the bedside. This is an example. This is the exam, and so this is published in 1990. That's about the time I'm finishing my fellowship or getting ready to start it. And during my fellowship, the basically operating strategy was you need to operate based on physical exam and history, right? You need to be able to feel the olive. And this is feeling the so-called olive. It's a curious disease if any of you are aspiring pediatric surgeons or pediatric surgeons. So the full name for pyloric stenosis is idiopathic hypertrophic pyloric stenosis, which means it gets big, the muscle gets big, we don't know why, and then it just goes away. And so it's a very curious disease. This is not exactly how I was taught to do it. I always examine from the bottom. But when you know how to do it, there is a way to pick the kid up from the feet and sort of palpate. You can actually rub the little so-called olive against the spine and make the diagnosis. And we would operate based on that. So the classical history is the parents will say they're vomiting. Just to be clear, it's not drooling. When it's pyloric stenosis, it's projectile, and they'll usually do this sign. No, they're vomiting. And so it's got a velocity. And if you've ever seen it, it does look like an Exorcist movie. I mean, it's very impressive vomiting for a baby. And then we would feel the olive, which actually had about 3 steps of feeling it, because this baby is, I think, a professional baby posing, because I never saw a kid with pyloric stenosis that looked that happy and relaxed. They're always starving and irritable and et cetera, et cetera. But this was kind of how we did it. Now, it got supplanted with ultrasound, because the pediatric literature would suggest that in 90% of the instances, you should be able to make the diagnosis just purely based on history and physical. And so, but the disclaimer is, in order to do that, the muscle has to get thick enough that you can feel it in an awake baby. And so the babies would present, they were dehydrated, alkalotic, all those sort of bad things. And so when ultrasound came out, those pediatricians just order them. And the radiologists have gotten much better at interpreting them. Even I can interpret them, which is saying something. But this is one reason to care. There still are conditions that we treat based on history and physical, what we do at the bedside. This is another one. You'll see more of this in the internal medicine literature. They clearly are. History and physical was a big part of what they did, never so much as us. I always say you go into surgery because our differential diagnosis is like it's either this, or this, and then it's not surgical. And like, I don't care, like consult somebody else. I'm moving on to the next thing. If you're in infectious disease or whatever, obviously elaborating very extensive diagnostic possibilities is a big part of what they do. But this is a quote from Osler about the value of bedside teaching, and that is, you can learn it in a book, but unless you go to the bedside and apply it, you like haven't properly learned it. And that's probably true. And it's just, some of it just seems nostalgic, like this has always been a hallmark of what we do. And we've had our own example of that in surgery. So this was kind of, when you were an intern, we all got one of these because you're going to get called down. And this is really sort of looking at the pattern of different diseases that might require surgical therapy. So we certainly have had our own tradition around this in surgery. But I think just continuing to do a thing because that's the way we always do it is like the worst reason to continue to do it. I think to Jim's nice compliment that the reason I started doing educational research is I wanted some kind of evidence. Like I would say, I think I could teach this in this way. And at that time, there was no literature. And so you just kind of did things based on best guess. And to me, that was very dissatisfying. In the same way, just doing a thing because we do it traditionally is not a good reason. What you would want to do is to say, but let's, before we discard the tradition, maybe think about, is there some value to it? And then this one, and really sort of putting this talk together, because this is the world premiere of this presentation, is that I came across this article, said, now that's interesting, that what they're basically arguing is that by going to the bedside, we can begin to think about cognitive bias. And I said, oh, that is a really good reason to continue to go to the bedside, to continue to encourage our faculty to teach there, to continue to encourage our learners to take us there. So let's talk a little bit about this idea of bias. So if you know this book, won Kahneman the Nobel Prize, this idea of thinking fast and low, and he's arguing that cognitive biases are the result of the fact that we're thinking quickly and reaching conclusions quickly, the system one thinking. For those of you who haven't read the book, it's actually quite interesting and accessible. This is the difference between system one and system two thinking. System two is analytical, deliberative, it's inductive in nature, and it involves sort of your higher order thinking. System one is when you're moving quickly, right? So you're in clinic and you're really doing pattern recognition, is what our literature shows, that what experts do when they're making diagnosis is very quickly, they're saying this constellation of signs and symptoms is this diagnosis, go. And that's like Jim and I were talking about, that as healthcare has changed, that one of the things that you deal with in my clinic is trying to determine, is a disease actually present? Like I get referred a thing and you're like, but you're a well person. But I'm there because the pediatrician's nervous or whatever, the nurse practitioner's never seen it before. So that's part of your thinking, is diagnosing wellness. And then this idea that it takes place in the kind of hindbrain is an interesting concept. So this is just a short set of things that I felt like that I needed to confess that I've been guilty of. There's, in this full article, if you want to read it, there's like 20 of these cognitive biases that can occur. So this idea of confirmation bias, you see that more is popular among conspiracy theorists when people say, oh, this happened. Oh, yeah, see, that's just additional evidence of what I was believing. Overconfidence seems like something that as surgeons, we're always confident, even when wrong. And so we're like, no, I think I really have this right. Search satisfying is interesting, is that you think about it until you get to the right thing and then you're done. There's a related thing that's a jeopardy for those of us who are older called premature closure, that we see it, we say, this is what it is, we go on. We don't, like a learner might say, well, is it this? Could it be this? We just don't do it. Like I remember getting a memorable call from an intern when I was a chief resident general surgery. Patient had abdominal pain. I said, what do you think's going on? And he said, well, it could be a black widow spider bite. I said, granted, that is in the differential diagnosis for abdominal pain. Is there any history of like an adjacent interaction with a black widow spider? No, there is not. Okay, so that's probably not the leading diagnosis. But this idea that at least he was introducing something that was plausible, something I probably would not have thought of at 2 a.m. And there's this idea of diagnostic momentum. And I think this is actually an interesting thing to contemplate, because I do think that because we're doing lots of team-based care with these handovers, there is a jeopardy for that. Like if one of my partners said, yeah, we talked about it yesterday, and this is what we're going to do, which is now my responsibility. And you're like, wait a second, that's got to make sense, right? I'm not going with whatever y'all decided yesterday. I've got to be convinced that that's, I'm still famous at UAB because the fellows had posted a appendectomy in the morning. I went in and saw the kid, and the kid basically cartwheeled out of his bed and was doing backflips in the hallway. And I said, I'm not doing an appendectomy on this kid. And that the nurses were like flabbergasted. They said, we've never had the attending just overrule the fellow. And I said, well, the situation changed. I'm not, it's me. I got to make a decision now. Everything else to that point was advice. But we sort of do this as individuals as well, as it will just sort of selectively take the information. And there is a little bit of this, like I always thought the sport as a resident is I see the patient, I come up with a plan, and then I am going to try to persuade the attending that my plan is the superior one. So there is a competitive aspect, but you got to tell everything, right? It's not fair if you're withholding information, or you can certainly emphasize what's useful. To me, this is a little bit, one of my surgical education heroes is Caroline Moulton talks about this in the operating room, that part of what expert surgeons do well is not just operate fast, but know the point where it's time to slow down, right? So in the same way, I think we could apply, that's really system 1 and system 2 thinking. Like I'm moving along, this is very automatic, we're fine. I used to tell the medical students, a case is like a symphony with 3 movements. If you want to ask questions or make comments, do it in the opening, do it in the closing, particularly if people seem happy, right? In the middle part where everybody's quiet and focused, not the best time to introduce something if you see everybody super focused. Also, if they're grumpy in the third part, not the best time, just, best time, just get out of the room as best you can. But this idea that as experts, I shouldn't be teaching my trainees, just go fast. I need to teach you to say, yeah, time matters. We only have so much of it on the planet, and it's expensive in the operating room. But by the same token, when do you need to slow down? What is the critical part of the case where you have to really be super careful? I do think in retirement, I'm going to write a book entitled Things the Attending Say Because We Have Nothing Else to Say. Like, be careful. Like, when would you not? Like, when would you just say, be carefree? Do whatever. Pass pointing, like, don't pass point. Like, when would you say, feel free, take all of the liberties to pass point. This is an excellent time to pass point wherever you want to. It's like we say it, it's just to say something. So this is another thing, in addition to teaching people, hey, you need to slow down, you need to think about that, what's going on here, which I think you'll see is built into the 2 models that I share with you today. The other one is this, and this is the exercise we're going to do now, is to think about our thinking. So we don't want to have these biasing things. We want to get to the correct diagnosis. And so the thing that we do is called metacognition, which is to think about my own thinking. And it's just as I gave you the example, as a senior surgeon, then I have to challenge myself to say, this seems to be this, what could I be missing, right? That's been my discipline as I've gotten older, is to say, don't do confirmation, don't do premature closure, but challenge myself to say, okay, take a second, what else could this be that you're not thinking about? So this is the first model originally described by David Irby, called the 1 minute preceptor model. It's also called 1 minute teaching. So it literally is a process you should be able to do in a minute. So that's very attractive to me because we're all in a hurry, but I should be able to spare a minute. And I think you'll see when you see these things, you literally can do it in a minute. So basically it has the 5 steps. You identify the needs of the learner, or it has these goals. I'm trying to calibrate my teaching to what you need to know. The alternative is to teach you something you already know, which is boring, or to not attend to a need that you have, which is not good either. And then provide feedback, which is there's a chronic, perpetual sort of curiosity about we don't seem to be able to get feedback sorted out. This model then would allow you to do it. And where it's been studied, and it's been studied extensively, it produces these outcomes. You get better ratings as a teacher, improve satisfaction, and it does improve the quantity, at least, maybe the quality of the feedback that we provide. All right, these are the 5 steps. And so I use a thing called multimedia theory when I design my slides. And so I purposely pick the pictures to go along with the words, and then I try to illustrate that in the story. That's called multimedia theory. And so you can see that I picked 5 steps. Get it at the top of the slide. So the 5 steps. So you should be able to remember the 5 steps in the teaching forevermore. You get a commitment. You probe for supporting evidence, you teach general rules, you reinforce what was done right, and you correct what was done wrong. That's it. That's 1 minute teaching. Again, adapted out of family medicine and primary care. So what I'm going to do is go through and sort of define more thoroughly what I mean by the 5 steps. And then I'm going to give you an example of questions, if you're a teacher, that you could ask. And by teacher, I mean all of you, because whether you're an intern to a fellow, you're teaching people all the time. And this is a very helpful model for anyone you might teach. So the first thing is to get a commitment. And the teacher asks an open-ended question to encourage the learner to commit to one or more aspects of the assessment or management of the patient. So it's funny, like one of the things I find funny in surgical education is in the operating room, I'll ask like the intern or the second-year resident, like, what experience do you have with this operation? And what I've learned through the years is they're always going to exaggerate their experience, right? Because the consequence of them being brutally honest to say, I've never heard of this operation, I've never seen it, I didn't have a chance to look at it on YouTube or read about it using Google, then I'm going to say, well, then you're going to watch me, right? So there's a game that we play in a case where they're going to exaggerate their experience with the hope that they'll get to do more. I just find it a curious example. The same sort of gamesmanship happens, like if I go to you and say, what do you think is going on? There's 2 strategies I think that are fun to just listen for when they do it. One is people, like the learner will start giving you multiple options, like it's a multiple choice test. And I think they're just hoping that I'm going to pick the right answer out of the 5, like it's a multiple choice test, and says, yes, out of the 5 things you gave me, you've identified this correctly. I won't, because the whole MHPE thing, I'm just going to stand there and let them kind of go through the other one. And my favorite is they'll pose what they think is the answer, but as a question, which it'll be like biliary atresia. And so there's this upward inflection on what they think is the answer. And I just think it's funny because what they're trying to do is get the right answer, but at lower risk, right? So they're not making a commitment because they're concerned, I could be wrong. We're wrong in surgery, but we don't have the luxury of being uncommitted. That's the always confident sort of business. At some point, I always feel like with perioperative decision-making, we take lots of information and then you reach what I call the light switch moment. It's either go or not go. Right? I'm either launching the rocket, I'm not launching. We're going to go and do this case or not. Then once you get in the case, of course, it expands back out. But this is what you're trying to do in this thing about, I just need a commitment from you. The other thing that's interesting to do is that people will pose answers like purely as questions, like they'll pose it back like, in this, and I'm like, wait a second. And I told him one time, and I said, hey, you're asking me a question. I already asked you a question. So I finally said, if you'll answer my question, I'll answer your question. So we had to negotiate to an arrangement. So again, it's just part of kind of gaming that happens. So here's a couple of examples of things of getting a commitment. What do you think is going on? And then a lot of my conversations that I have with my fellows is to say, I actually start at the end and I'll say, what is your plan? Right? And that really throws them off. And then I kind of work them backwards. Well, what do you think is going on? Actually, what is your lead diagnosis? And that's this idea of getting a commitment. And I like this because surprisingly, because family medicine docs are very, social and very gentle, but this is actually, you're kind of putting the learner under a little bit of stress to say, no, I need a commitment, right? And so I think this is why one of the reasons I'm attracted to this particular model. And then you want to support for for supporting information. So a funny story I heard didn't happen to me at a graduation is a physician was recounting that she was getting ready to do the pediatric rotation. So she, for some reason, thought it would be a good idea to read about congenital anomalies and inborn errors of metabolism. Like, oh my word. And so she was in clinic and she went in and saw a patient and recognized that the patient had a condition called Menkes kinky hair syndrome. You can look it up later. It's a thing. And like I would have been flabbergasted if I said, what do you think this patient has? And the learner had correctly said, well, that's clearly Menkes kinky hair syndrome. The teacher, who's world class, said, what else could it be? And it was like, wow, I just would not have had that equanimity in that moment. I would have fainted if they'd actually gotten that right. But this is this idea to sort of say, like, where is this coming from? So every year when we have our chief residence dinner, to me, that's the best program evaluation information I get, because they're going to make fun of me. And what they'll say is largely true. And so they would talk about, I keep saying why, like why, and about the fourth why, you're into like metaphysics and philosophy, because like nobody knows. And so, but you just keep compelling them to justify. So it just wasn't a lucky guess. And it's really about trying to get to deeper level learning to say you need to justify your answer, because otherwise maybe you just got lucky, or maybe somebody on the team said it and that sounded right to you. I'm going to really push you down to get the supporting information. And these are some really good things. Now, I'm learning about coaching, and you're really not supposed to ask why questions because they get people defensive, but there are other ways to do it. I like this. What are the other factors that led you to consider that? Because to me, what we're trying to do is compile evidence, and so it fits a pattern sort of diagnostically. But these are all ways that you can push people to get to supporting evidence. That's the other thing. They gave me a teaching award last year, which was lovely. And they would say that I always compel them to justify things with evidence, because they're like, we're going to do this. And I'm like, on what basis? Like, on what basis are you recommending that? And they, I think, appreciate that in the long run. Not sure always in the moment. And then this idea is a little bit more of a struggle, and that is this idea of bringing it to a general sort of a general rule that can be applied to other circumstances, which I do think is a helpful thing to sort of think about as a teacher. What is the general rule? Again, drawing, and these are all papers from questions are from a paper, and I'll show you that paper in a minute. But remember this, the key points. So I was thinking about this for me, like key points that I would have general rules is, if they call me with an infant with bilious vomiting and a question of malrotation, if malrotation comes up in the consideration, get the study, right? That's a general rule. You don't play with malrotation. And invariably, they will call you at 2 a.m. Well, the kid had a little vomiting. It was slightly yellow. We're worried about malrotation. Excellent. Get the study. Thank you very much. Call me if it's malrotation. Click. That's all I have to know. Hirschsprung's. A general rule is don't try to outsmart Hirschsprung's disease. It will beat you every time. It's just too diffuse variable in what you do. So those would be examples of general rules. One of the rules that I have to do, because I was described by one of my partners very accurately, is I'm very conservative until I become hyper aggressive as a surgeon. So what his point is I'm going to push you to say, do we need to do? Is this the right operation at the right time on the right patient? But once we're in go mode, I'm ready to go. Like, what are we waiting on? Let's go, right? In the same way. And so as a general rule, what I say is if I'm ever on the fence, like I'm 50-50, should I do a laparotomy? Should I not? I'm going to say go, because I would rather make the mistake of intervening than to justify not intervening when it was needed. And that's from giving M&M for many years, giving depositions. I would much rather explain to people why I acted instead of why I didn't act. That's just a general rule that I'm sharing from my crystallized knowledge. And then this too, reinforce what was done right and then correct mistakes. So I don't know who all seeing this in Zoom land, but I'm sure there's some skeptics out there, and you're probably saying, okay, this is why you win teaching awards, because you're coddling the residents and you're telling them what they do good, and you're a pediatric surgeon, you're probably hugging them if they need it and all that. But there's real value to reinforcing feedback, particularly with younger learners. And basically what they're saying to do here is pointing out when you did a thing right. So when I was, my very first rotation as a surgery intern was on neurosurgery, which was completely discombobulating to me. So I worked really hard. I did what they told me to do. I would run to the OR and help close the scalp at the end of the craniotomy. And at the end of it, the division chair took me aside. You've been the best intern that we've ever had. And I said, thank you. And that was lovely. And I had no idea what I had done. Like, I had no idea why I had had this historic achievement. And that's the problem with not giving reinforcing feedback, particularly to people that are new, whether it's the medical students early in the year, interns. So you did a good job when you did this. I really like the fact that you would pull all this together and present it in a coherent way. It's actually an interesting commentary on child rearing, and my babies are 30 and 33, so probably I'm just paying for their therapy to correct my mistakes in parenting. But one of the things they say is that in parental feedback, this should be about 90% of what you do. Our comments should be way more reinforcing than they are corrective, in terms of like, because we typically are, it's all corrective. Like, you need to do this, you need to pick up your room. Never, you did a lovely job picking up your room. Now with my youngest son, he never cleaned his room, so I never had the opportunity to be reinforcing. Although now, curiously, he keeps his apartment quite neat. Go figure. So, but these are just examples of pointing out what you did well. So particularly when you're an intern coming into Stanford, you've not been here before, to say, yeah, you did this really well. That met my expectations is a helpful, it increases the probability they'll continue to do that. This is the area more common to us, this idea of corrective feedback. And I like the sequencing for a couple reasons. And one is this literature that shows that when I give you feedback that's reinforcing, like I say, you really did a nice job doing that, and you thought you did a nice job, that you're like, check, check, good, okay? When I give you corrective feedback and you knew it was coming, you're gonna struggle with that. The most difficult is if you think you did well and I give you corrective feedback, it takes a bit for people to kind of do a journey. And that's why it's important to give the reinforcing feedback in front of the corrective feedback, because when you give the corrective feedback, they don't hear the reinforcing. They're kind of in a thing. They're kind of having to go through a struggle of, oh, I thought I did good and I didn't do good. And now I don't hear what you're trying to tell me where I actually did something right. And this is not really the purpose of this. This is why I really like the Pendleton model, where you ask the learner, what do you think went well? At the end of a case, what do you think went well? And then I can confirm, what do you think you could have done better? And then I can confirm. And then I may give you some tips for how to get better, which is the whole point of being a surgical teacher, is to trying to help people improve what they're doing. The other thing I like about this is all of us are reluctant to give feedback. So spoiler alert for those of you who are residents, it's hard as an attending to give corrective feedback to trainees, because we have some deep-seated need to be loved. And so when I give you corrective feedback and when you cry, I don't feel good. And so I lack courage to do it. But I do a thing called Surgeons as Educators. Every year we have 30 like world-class educators come in. We have them do a 5-minute presentation of themselves doing a presentation. Now, these are people that have done hundreds of presentations, and they're all quite good. And invariably, I'll say, what do you think was good? And they'll say, nothing. That was the worst presentation in the history of humanity of giving presentations. So we're all very self-punishing, highly perfectionistic. And one thing about this to help the teachers is if you let a surgery resident do this, you end up like just giving them the good stuff because they're so self-critical. It's like you're actually saying, no, you're actually doing this well. And you end up pointing them mostly to the things that you want to reinforce or even give praise about. So the article that I showed you, the really great questions, I thought they were really good questions, actually came out of the veterinarian literature where the 5-minute thing has been adopted. So it turns out, and maybe some of you are bulldog owners, but apparently nasal stenosis is a big problem in bulldogs, right? And so this veterinarian student said, hey, I'd really like to focus on the bulldog nose today and understand that. But I said, that's just hilarious. But it is an interesting sort of affirmation of this model that it's been so widespread. It's actually been taken up by veterinarian bedside teaching. The other reason I like the whole 1-minute preceptor model is it satisfies theoretically like how we think people learn, and that you're putting people into a reflective phase and asking them to elaborate concepts. And so to me, it's just, you know, I'm curious about theories of learning. It is not going to cure all your problems. Here was a really nice study that shows it doesn't fix a lot of the challenges we currently have in teaching. It's not going to fix that you don't have time, you don't have sufficient help in clinic, there are productivity demands. It will give you a framework to do. So it's a real thing. It's not going to like change your world, but I do think that just adopting even one of the practices from the 1-minute preceptor model will improve teaching for anyone interested in doing so. Just briefly to give you another model, some of you are attached to the MHPE program. So I remember when Terry Walpo first came out with this model, and then she's continued to work on it for 20 years, called SNAPS. And here you can see the model. It has a lot of the same concepts that the 1-minute manager is. I don't know how you remember things, but it's like a snap. But it's got 2 P's, so you got to remember all that. But this is kind of the model. I just mention it because it's been way more extensively studied than the 1-minute manager. So if you said, okay, I'd like to study that in a surgical context, lots of good things. It shows that it produces really positive learning outcomes. And this is just to compare the two, the 1-minute teacher, 1-minute preceptor model versus SNAPS. What's interesting about SNAPS is it really puts the burden on the learner, because you can see in the bottom P, it's the probe the preceptor about uncertainty. So to me, it's more appropriate for maybe a more seasoned person, a chief resident or a senior student. I might say to them, you need to like ask me questions in this model at the end. What are the questions that you have? I don't know, for whatever reason, I've only ever had one resident that had the courage after I had given her, as it turned out, feedback at the end of her rotation. She said, now I'd like to give you some feedback. And I said, oh, interesting. I've never had somebody had the nerve, but cool. And so she said, what happens in a case, like you'll say, be careful with the vase. And then if I don't do it, you just say it again, like be careful with the vase, right? Be careful with the vase. She said, you're just saying the same thing over and over again. It's actually not helpful. And I said, yeah, very good. So I changed it up going forward, but it's just something that's just been unusual in my experience. Okay, so as I move to sort of, because I'm interested in your comments, rebuttal, skepticism, genuine disagreement, whatever. Again, to say the challenge is, I think that actually there are people in this room that will make a considerable contribution in surgical education. What I would like to propose to you is the possibility of focusing on bedside teaching as a surgeon, and I'll explain why in the next slide or so. Just to acknowledge, there's been a little bit of work on this. This came out of SIU. Roger Kim wrote a piece that's really a conceptual piece around bedside teaching. It's really not a lot different than what I've talked to you about, although the idea of cognitive bias and sort of using bedside teaching around that, they don't really address it in there. But if you're interested, I think this is fair. They got out there and sort of commented on it. This is a recent review for like tools, deliberative teaching tools for clinical teaching encounters, a so-called, they said both a scoping review and a thematic analysis, which is an interesting amalgam of methods. But basically, if you scan the list, and I realize there's only like 2 in here that relate to surgery in this entire list. So bedside teaching by surgeons is to me a woefully underexplored aspect of surgical education. And even in my presentation, I'm basically adapting what's been done by internal medicine and family practice for a surgical purpose that needs to be studied. So stay skeptical, even if it's me saying it. This is a nice thing to get you started. It's already an assessment piece that Reed Williams and Gary Dunnington, among others, developed when they were in Indiana. And that is, they've already sort of thought about, like, how would you assess bedside teaching? And so it's really nice, really hasn't been followed up on. And in this, I encountered, and it's like, wow, the people at Stanford Surgery already have a kind of built-in advantage. So you've already done this work here in internal medicine with the so-called the Stanford 25. Now, we're surgeons, y'all, so this got to be like the Stanford 5, the Stanford Surgical 5. I don't want to have 25. And P.S., last time I went to my internist, I don't think he did 25 things, so I think I'm getting ripped off. But it's already some work, and I think we need to do the surgical equivalent to say, what are the fundamental things that we need to be teaching as the world changes and we have ready access to images, we have ready access to labs. What are the critical elements, not for traditional purposes, but because there is value to be gained from the history and physical? Because we really need that information to understand how to really properly do bedside teaching. So if you take up my challenge, and I hope one of you will, and apply for a grant, I really like this concept of so-called precision medical education. So you could use that in your grant proposal to say, what I'm proposing is we would do this work in an effort to develop a surgical version of precision medical education. And that basically is trying to take all of this information, make it accessible to the learner. There's no sense in acting like the x-rays aren't available, they are available. But how do we integrate that into everything we do at the bedside to do the decision making? Even artificial intelligence will come along as a computer-assisted diagnosis and all that thing. It's still, at the end of the day, I think, it's still going to be people making decisions about patient care. So basically in this presentation, I've talked a little bit about kind of my journey, some observations, what's happening in healthcare. I've tried to make you care about the topic of bedside teaching. I do think that the 1 minute preceptor model, 1 minute teacher, has some things in it that would improve your teaching if you're interested. And there's no reason why, if you're not a senior resident for the students, just try some of these things and see if they work for you. And then I've sort of laid out a challenge, because I think that there's a history in this department and there's the talent in this department. Granted, you got to do what you have a passion for, but I do think there is a ready opportunity for a surgical educator to make a substantial contribution, because there's so much that we don't know about this topic. So thanks very much, and I'm happy to hear your questions and comments.